Hi everybody, welcome to our Facebook Live. Today I'm with Dr. Eric Bush. He's the Chief Medical Officer here at Hospice of the Chesapeake. And today's conversation is going to be about accessing supportive care through palliative medicine. So I know there's a lot of misunderstandings about palliative medicine and hospice care, and are they the same thing? So let's start with talking about palliative medicine and the definition of it and sort of what it is and how it's different than hospice care.
Sure. So palliative medicine, unfortunately, has gotten a bad rap, so to speak. It's been used synonymously with hospice care, and palliative care actually is not synonymous with hospice care. Palliative care, actually, the Latin root palliate actually means to cloak. And so, yeah, which I think, and if you think about along those lines, a lot of what palliative does, which really to me can best be described as supportive care throughout anybody's journey of illness, that's really what we do with palliative care, is we're able to cloak or mask symptoms, provide support, provide guidance with regards to goals of care, advanced directives, some of the things we talked about several weeks ago.
Right.
So to me, really the term should be supportive, because supportive is more encompassing and really more in line with what's done clinically. The other piece too is, much like we have our palliative branch or Chesapeake Palliative Medicine, a lot of community-based palliative care in this country is provided by not-for-profit hospice organizations like Hospice of the Chesapeake.
And why is that? Why do you?
Really, it's in line with the mission of a lot of community-based hospices, and if you think about meeting patients and families where they are,
right,
and serving the community, it was seen in essence as an unfilled need.
So just sort of getting a little bit ahead of the game,
Correct.
Honestly, like
Correct.
Just trying to back up care a little bit sooner, so that whole journey can be a little bit gentler, I'm guessing, or easier for the person.
Correct.
Okay.
But we call it moving the care upstream.
Okay.
So again, ideally, as somebody goes from having issues that are medically curable, and the burden then becomes at some point more uncurable or incurable, and you want to focus on quality of life as well as quantity of life and supporting patients throughout their treatment course. A good example would be patients with cancer, a late stage 3 or stage 4, and if you think about the burdens of or toxicities of chemotherapy, whether it's traditional or even immunotherapy, and supporting patients through that, so treating things such as pain, nausea, shortness of breath, and also helping those patients and families determine at what point do they seek out other alternative treatments, clinical trials, working in conjunction with the patient's oncologist and primary care physician to help guide their treatment course as time goes on, as that risk versus benefit for those interventions that changes over time for the patients.
So let's go back to your example of a person that has cancer, and it's the late stage 3 or 4, that they've gotten that heavy diagnosis. Would their oncologist be the person? I mean, I think I've heard sometimes that oncologists say themselves that they're providing that palliative care. So why would someone need to schedule a separate appointment or go see a palliative specialist? Like, what's the benefit to that?
So the benefit is very clear in that patients not only get better quality of life, but often more quantity of life.
Okay.
And there's evidence to the point that it's actually a recommendation by 2 oncologic societies. So the American Society
have the specialist of a palliative medicine specialist.
So, and the way it's worded is that at time of diagnosis, the patient should be referred to palliative care.
Okay.
And that's by both ASCO, or the American Society of Clinical Oncology, and NCCN, or the National Comprehensive Cancer Network. And NCCN has a multitude of guidelines with regards to not only what treatments the patient should receive, but also regarding palliative or supportive care services.
So gonna stick with the cancer diagnosis.
Sure.
So that person that has the late stage, they are having trouble. They're still seeking curative treatment. They're
Absolutely.
still getting the chemo, and they're still, doing clinical trials or whatever, aggressively trying to treat their disease. That person could still benefit from palliative medicine appointment specialists going to see that person as well, because from what I hear what you're saying, you're going to be able to really focus on the symptom management and then sort of look overall at that person's care and
Correct.
sort of map out what's going to be beneficial moving forward.
Correct. And
Okay.
what I can tell you is that I've been blessed enough to have had the opportunity to serve multiple patients that have been able to see that benefit. I have a patient who was diagnosed with stage 4 colorectal cancer back in December of 2011, who will be with me now 8 years, has been able to get multiple lines of chemotherapy and other treatments, has had pain, nausea, a lot of issues because of the surgeries involved with colon cancer. Another patient who's been with me since 2010 that has had a chronic leukemia, and again, we've been able to manage her symptoms, and again, sometimes it is physical symptoms, sometimes it's more just supportive care and just being there and helping guide their course. She's currently receiving clinical trial, so helping her navigate through that and support her through the challenges that may present to her and her family.
So how long would a typical appointment be if someone sits down and is having a palliative medicine appointment?
Sure.
What's sort of the timing for that?
Sure. So typically an appointment is an hour and a half to 2 hours. So it's kind of like 6 to 7 regular doctor's appointments all wrapped up in one.
Okay.
Because again, the degree of complexity for palliative patients tends to be very high, and we want to make sure that we are getting good, clear picture of all that is going on, all that is important to the patient, where that intersects with the medical piece of it, so we can provide them the best guidance, the best advice, and the best treatments in order to support them at that time, as well as planning for down the road.
So who's giving that appointment? Is it a physician? Is it a nurse practitioner, a nurse? Who does that
Sure.
hour to an hour and a half?
So typically it's a physician or nurse practitioner,
Okay.
but it can be a social worker or a nurse.
Okay.
We do have multidisciplinary palliative care here at Chesapeake, supportive care, Chesapeake Palliative Medicine.
Okay.
And so it may be one, or sometimes it may be several. Sometimes it may be me and the social worker, or a nurse practitioner and social worker. That's also a possibility.
So I'm blown away by that amount of time.
Sure.
And I just think it's really important to sort of make sure folks understand that if you are having that long of an appointment with a nurse practitioner, with any medical professional, the things that can be uncovered and sort of prioritized and just really focused on, I mean, that's huge.
Yeah.
If you're just joining us, I'm Tammy Turner. I'm talking with Dr. Eric Bush. He's the Chief
Hi.
Medical Officer here. We welcome your comments, your questions, and we're talking about supportive care with Chesapeake Palliative Medicine and palliative medicine in general, but Hospice of the Chesapeake offers Chesapeake Palliative Medicine. And we've been focusing sort of on a cancer diagnosis of stage 3 or stage 4, but from my understanding, palliative medicine is an option for more than just a cancer patient, correct?
Absolutely. Like we touched on in earlier conversations,
Yeah.
It's really, if you're hearing that word advanced or end stage, that's a good time to ask your physician about palliative care.
Okay.
So whether it's congestive heart failure, Alzheimer's, ALS or Lou Gehrig's disease, other neurologic diagnoses such as someone who's had multiple strokes, if you or yourself or a loved one has had multiple hospitalizations,
Okay.
end-stage kidney disease, so patients in particular that are dialysis dependent and are older than 75. A lot of times we know that those patients, that's a higher burden of disease process, and they can benefit from palliative care. as well as a lot of patients with end-stage liver disease too. There's a large prevalence of non-alcoholic fatty liver disease.
Okay.
And so those patients sometimes that are awaiting, transplant even, they could benefit from having a palliative care consultation.
Okay.
So it's not just for cancer, COPD, and so again, personally, I've been blessed enough to be involved in a patient's care where we've been able to help her age in place.
Okay.
We started seeing her in December of 2017. A lot of chronic pain issues. She's had multiple surgeries, end-stage COPD, oxygen dependent. She did have 2 hospitalizations during her time with us. She then, earlier this year, unfortunately, one of those hospitalizations had a fall, broke a hip, was able to get through rehab, and we were able to get her back home and independent. And she then enrolled in hospice in the beginning of July, and fortunately, we've been able to keep her home and keep her comfortable. She has a wonderful supportive family. But again, we do help patients age in place, initially with palliative, and help with that transition to hospice when appropriate.
So that's just another benefit
Correct.
of doing that sort of upstream
Correct.
care that you were talking about. It kind of just helps smooth the
Forming
process
those
out.
relationships with
Yeah.
patients and families, and getting to know them and what their desires are and when they want what kind of care,
Right.
so we can really individualize that kind of care for them.
I think one of the other things, and this is, I know, a challenge just for most common folks coming into a medical appointment, and the medical terminology, and sometimes that's discussed, and especially if you're having, a complex health issue, there's a lot of lingo and language that's hard to understand.
Right.
And from my understanding with palliative medicine, sort of that service that's offered is the bridge to
Correct.
communicate, to sit
Correct.
down. You're having that hour to hour and a half to really sit down and process through all of the diagnosis and the
Right.
complex issues.
Correct.
Okay.
Absolutely, and there's some great resources out there. One of them is put out by the Center to Advance Palliative Care, and it's a very easy website. It's called getpalliativecare.org.
Okay.
And if you go to getpalliativecare.org, there's actually a 5-question screener on there
Oh, awesome.
that is put in very simple layman's terms that people can answer and then determine what benefit they could get from palliative care, eligibility. In addition, there's a nice area on the website where all you need to do is put in your zip code, and it will tell you who is available as a palliative care provider for your local geography. So if you put in 21122, we would come up.
Okay.
So it's very nice because access to palliative care in this country has improved over the last 2 decades, but it's still primarily provided by hospitals,
Okay.
including here in Maryland.
Yeah.
And
that's internal in hospitals, not
Correct.
necessarily outpatient.
Correct.
Okay, just wanted-
Although if you go to getpalliativecare.org and you do not see an organization there, you may use your local hospital as a resource
Okay.
just to kind of backfill and give them a shout and say, hey, do you know of any palliative care providers here in the community that could benefit myself or my loved one?
Okay.
So it could be used that way as a resource.
Okay.
About 85% of metropolitan areas in the country have good access to palliative care, but only about 50% in the rural areas. So there's still an access to
gap.
care challenge. That in addition, for each palliative provider, i.e. physician or NP, there's about 1,700 seriously ill adults, and the World Health Organization estimates that only about 14% of those that need palliative care actually get it.
Wow, such a gap.
Yeah.
Wow.
So
So, all right, we've talked a little bit about who can benefit from palliative medicine. We've talked a little bit about, why it's helpful, because we can sort of use that large, and I keep going back to the large amount of time, but I think that's huge in our healthcare, situation the way it is now. If you have 20 minutes with your primary care provider, you feel like you've had a good day.
Right.
So I'm just always blown away by the, hour to hour and a half plus that you get to spend with a palliative medicine specialist. I want to back up a little bit with
Sure.
people that are trained in that. It is a specialist, right?
Correct,
It's a specialty. It's like an oncology or cardiology.
Correct.
It is a specialty in medicine.
Correct. So it's an American Board of Medical Specialties specialty.
Okay.
It is fellowship only as of 2013. It's an additional 1 year fellowship beyond a residency. So myself, I was fortunate enough to complete that at the National Institutes of Health.
Oh wow.
And so, physicians that are boarded in it do complete fellowships. Nurse practitioners also are able to get boarded in hospice and palliative medicine.
Okay.
There still is an experiential track. And so what we do here is we expect our nurse practitioners to be boarded within 2 years after starting employment with us.
Okay.
There is an additional test in order to get that credential.
Gotcha. So it is a specialty. So
Correct.
okay, I'm guessing people are probably like, this just sounds too good to be true. There's got to be a heavy price to this. How does one pay?
Sure.
I'm sure that's like on most people's minds because healthcare is not inexpensive. So how is palliative medicine paid for?
So we're paid just like any other specialist. So just like you would go see your cardiologist, oncologist, pulmonologist, your primary care doc. There may be a copay involved.
Okay.
But again, almost all insurers at this point cover palliative care.
Okay.
And they see the benefit of palliative care. So we're reimbursed just like any other specialty.
All right. Great. That's good to know.
Mm-hmm.
And where does one
Sure.
receive this wonderful
Sure.
service?
So again, depending on the organization that serves your area locally,
Okay.
what I can speak to is our organization would provide wherever the patient calls home. So in your residential home, SNFs, ALFs, ILFs.
SNF is what?
I'm sorry, so
That's
skilled
all right.
nursing facilities,
Okay.
nursing homes,
Gotcha.
independent living facilities,
All right.
assisted living facilities.
Okay.
We have an ambulance.
So the nurse practitioner or the physician would go into these
Correct.
places to meet people
Correct.
where they're okay.
If somebody's functional status is to the point where it's too much of a burden to have them come to our office here on campus,
Okay.
by all means, we see patients at home.
Okay.
It's provided also obviously in hospitals. We touched on that.
Okay.
And then some organizations like us have an on-campus office, just like you would go see your primary care doc, or again, any other specialty. It's what we provide here.
Right,
too.
so in Pasadena, just
Correct.
to clarify that a little bit, we have the Hussman Outpatient Care Center that's located in Pasadena, Maryland, which is a
Correct.
great resource for folks, especially those that, I think the benefit of having someone come to your home is great, but sometimes people, you don't want that in your home. You go
Right.
to your doctor's appointments and you want that professional experience going into
Right.
a outpatient center,
Yeah.
so it's
Those
great that we
patients
have
that I mentioned earlier, the ones that have been with me for 8-9 years, they all come here and see me.
Okay.
Absolutely.
All right.
Yeah.
So we'll put the link for the website
GetPalliativeCare.org.
that you recommended in our
Yes.
comment sections. We've talked about how it's paid for, where you can receive it. Do you need a referral?
So you do need a referral.
Okay.
It's important to get one either from your primary care physician or any pertinent specialist. It's just we do want to be part of the team for care, so we do want to make sure that your other providers are aware that we're involved in your care. And so also we can communicate with them because that is so key and so critical as
To be
time
part
goes
of the
on.
bigger picture
Exactly.
team. Okay.
So we want to know who to send notes to, who to collaborate with, who to communicate with.
Okay. All right.
Correct.
Good to know. So I think the big takeaways for understanding supportive care and palliative medicine is that number one, it's different than hospice medicine.
Correct.
It is a different type of care that can be held earlier if you have the serious illness, it can be held earlier to give you a better quality of life. It can go in conjunction with treatments and curative treatments that are going on. And it's really the goal is to get that supportive care and help with symptom management, help understand the whole illness, and just really kind of get better quality of life.
Exactly, help patients and families navigate their symptoms, whatever those may be,
Okay.
or if not, help them navigate that treatment course and their goals to help optimize quality as well as quantity of life.
Okay, all All right, awesome. We will be sure to put in our comments the number for Chesapeake Palliative Medicine if anybody's interested in getting more information or for making an appointment. Thank you again
Great, thank you.
for being here, and thank you guys for watching.
Great, thanks a lot.